Thank you very much. It's a great pleasure to share this. And I think we should just need to be attentive, because if you don't ask me questions, it will mean you did not understand. Because this aspect of healthcare is what many of us are very strange to. We don't understand it, but we're going to make it simple. We are going to talk like community physicians, and we're going to make it clear for everybody. So we are talking about the new the implications of the, you can see the topic, the new National Health Act. I changed it from new National Health Bill to Act because currently there's no bill, but it is the National Health Act, which was passed in 2014. Then go to the next slide. Yes, at the end of this presentation, this is what I expect that we would have gone with. Now we would have understood the background to the national health policy and programs and the evolution of the Nigerian health system. Number two is that the key issues of the National Health Act 2014. Number three is the Nigerian Health Insurance Act 2022, the Basic Healthcare Provision Fund, which is consequent on 2014 Act, and some specific issues of concern to CMDA as a body. Then some basic responsibilities of healthcare providers and the challenges, of course, the way forward. Next. Okay. In order to achieve what I had said as our takeaway or outcome, we will use this outline: introduction and background, peculiar health system challenges in our setting, evolution of the Nigerian health policy, the National Health Act, the Basic Healthcare Provision Fund. Yes. Okay, so yes, the outline, except that what you see, you remember. What you hear, you can forget. Okay, I've talked about the outline which include introduction and background and precious peculiar health system challenges in our setting, then evolution of the Nigerian health policy, the National Act of 2014, the Basic Care Provision Fund, as I said, and National Health Insurance Authority, responsibilities of the healthcare provider, the state-wide approach, SWAP in brief, statewide approach, and the 4-point agenda of the federal government and other strategies. Then the CMDA and the National Healthcare Environment. Okay, the CMDA and National Healthcare Environment. We are going to relate this to us as it affects us. Okay, go on. Now, let's look at the central thought that will guide us, drive us. Nonetheless, everyone studying or practicing medicine is confronted at some point in life with the glaring realization that effective medical practice, which seeks to care for the whole man, is a calling. Many people are ill-equipped. Provision of such care will require that the medic is an effective Christian witness, having the capacity to practice after the pattern of the great physician, Jesus, our master, the model for the effective Christian practice in any profession. This is lifted from our logo exploration, page 9. It is from the driving concept. Okay, the background, policies, strategies, plans. Now, I want you to listen because many of us are busy with our stethoscopes and syringes and the scalpel and the knife and the swabs and so on. And we don't understand the environment under which we operate. And that is not good at all. We cannot be ignorant in our marketplace. Now, what are policy strategies and plans? What do they aim to do? One, they aim to align countries' priorities with the real health needs of the population. Now, they generate buy-in across government, health and development partners, civil society, and the private sector. And in fact, buy-in among CMDA will be one of the people that we need to have a buy-in. Make better use of all available resources for health. And when you do this, it means that so that all people in all places have access to quality healthcare and live longer, healthier lives as a result of that. Please go on. If you are hearing me, I can continue with my phone.
Yes, sir. We can hear you loud and clear.
Okay. Let's note this. Let's note this. The mismatch between actual performance of fragmented health systems and the rising expectations of society is becoming a cause of concern and internal pressure for health authorities and political leaders. This is what we need to note. There is a mismatch between the actual performance and what the society expects. Is a rising feeling that we are failing. Number two, these factors and others, including today's consensus around the importance of realistic costing and strong monitoring and evaluation, have translated into a renewed focus on strengthening countries' capacity to develop a robust national health policies, strategies, and plans that can achieve some objectives. What this thing is just telling us is that there is a pressure, there's a pressure mounted on the health systems. Society is not satisfied. The environment we see ourselves does not allow us to give our best. And there's a pressure, therefore, for every stakeholder to be on the alert. And therefore, there's a need to have a legal framework, a legal environment that will determine and decide and drive the practice of medicine in our environment. I want us to know that as Christian doctors, we are the one at the forefront. Now, when we have a good and well-articulated sector or policy environment, it will help to achieve the following. Now, it will respond to the growing calls for strengthening health systems through primary health care as a way of achieving the goal of health for all. This requires action on 4 policy areas. I want to explain. The health system has the mandate to implement the Health for All program, Health for All, health for everybody. It may not be the same level of health, but every Nigerian is entitled to a reasonable level of health that will allow him or her to live economically productive life. Whether they are in the hard-to-reach areas, whether they are in the cities, or whether they are in the slums, everybody is entitled to a level of health that will help him or her to live an economically productive life. That is what the Health for All means. It requires action like, number 1, moving towards universal coverage. You cannot have healthcare for everybody without universal coverage. In other words, the quantity and quantity of healthcare that should reach everybody should reach them. The level of health they will require will reach them. So we're moving towards universal coverage. Then the B is reorienting the conventional care towards people-centered care. I want us to be careful here because they want to reorient people, the conventional, like all of us, care towards people-centered care. People-centered because many times the way we practice medicine, we don't center it on people. We give a non-specific generalized approach to health without aligning it to individual needs, patient-centered care that will be tailored towards the need of each individual patient who is different when we come. And as Christian, you can understand what I'm saying. Now, the third factor among the policy to help us reach universal coverage, we need to integrate health in all policies. All policies of government should integrate health. We cannot do any policy without integrating healthcare in that policy. Now, the last factor is that ensuring more inclusive health governance. In other words, in governance in health, it should be inclusive, very inclusive. All stakeholders should be involved. Health is not only about medical practice. It has education in it. It has nutrition in it. It has sociology in it. It has so many things that affect people's behavior and attitude to health. So we need to have a more inclusive health governance. Number two, of the reason why we need to strengthen this system is that we want to guide and steer the entire pluralistic health sector rather than being limited to command and control plans for the public health sector. Now, what this tends to suggest is that we need to have a form of management in health sector that is inclusive, not verticalized. Somebody says it's malaria. It doesn't do anything apart from malaria. It's a waste of money, waste of resources, but to have integrated care. The same group of care using the same facility at the same time, they can do so much. And then the other one is that there is additionally in countries where external and plays a significant role, national health policies, strategies, and plans are increasingly seen as a key to improve aid effectiveness. Now, you have we have a system where we depend on so many people to do certain things. There has to be a coordinated way of making sure that these aids are coordinated and managed in a way that there will be economy of time, economy of resources, economy of personnel, economy of everything. The second point is to guide and steer the entire pluralistic health sector rather than being limited to command and control plans for the public health sector. The other one is to go beyond the boundaries of health systems, addressing the social determinants of health and the interaction between health sector and but that number 4, I like us to know that what is talking of, go back a little, just one slide back. Yes. Now, go beyond the boundaries of health system, addressing the social determinants. I mean, these social determinants, I want us to note as Christian doctors that everything is not physical. In fact, they say that because they say that health is a state of complete mental, physical, and social well-being. That means the social environment as a determinant of health is important, and many of us don't understand. There are so many social factors which has nothing to do with bacteria or germs or parasites or anything, but they are very important determinants of it. There are social laws. We are moving towards social norms now. How we can change the social norms that are against health practice, health behavior, because there are laws, unwritten laws that bar children from eating egg, bar children from eating meat. They will become thieves if they eat. These are social norm issues that you don't handle in the hospital. And except a Christian, you may not go down far to interact with people to understand them. Go on, I'll give you some testimonies. Go on. Additionally, in countries where external aid plays a significant role, national health policies, strategies, and plans are increasingly seen as the key to improve aid effectiveness. In other words, all these aids are coming from people. They don't come and determine for you what they want to do. No, the country should have a program where everybody that has anything to do, you give it into a common purse, and the country uses it to face its own priority health challenges. Not to come and tell us what to do, not to come and tell the country of the area you want to go. Please go on. Yes. Now, how has the Nigerian health policy, what is the journey so far? Remember, everything we have been saying are the reasons to have a policy, to have an organized system of doing things. Now, if you look at the basic BHSS, means the Basic Health Services Scheme. This was part of the National Development Plan, the third National Development Plan of 1975 to 1980. Those days, they used to have national development plans. At the time the Basic Health Services Scheme was introduced was during the 1975 to 1980 period. I think we can imagine when, I think it's Professor Professor Kuti was, I think Ransom Kuti was the Minister of Health at that time, made a lot of progress. Now, they introduced the Basic Health Services Scheme between 75 to 80. This was Nigeria's first attempt at implementing primary healthcare. Remember that the Alma Ata Declaration is 1978. Yes, 1978. But by 1975, Nigeria had already started moving towards primary healthcare and universal health coverage. This was the first time Nigeria did that. What were the problems with that? We need to have a feel of where we have come from. We discovered that the weakness of that program was that it concentrated on provision of health facilities and training of healthcare workers. But little or no attention was given to community participation and use of appropriate technology. That time, look at the cadre of healthcare provided trained community health officers, CHO, community CHS, community health supervisors, CHAS, community health aides, assistants, and then community health aides. That time, so many years, even up to now, some places, the equipment that were imported during that time, with nobody who has an idea how to use it, because they just built facilities and supplied without taking care to get the communities involved, get people involved so that they can empower people that will operate these facilities. We continue with the evolution. The fourth National Development Plan, we have started with the third, the fourth. Now this is the fourth, and this plan was 1981 to 1985. It succeeded the third National Development Plan, but did not achieve any significant improvement on the third one. Now the fourth did not achieve any significant improvement of the third it is replacing. What followed? Then Nigeria went to what they call rolling plans that had no time bound. They had no time-bound health plans. It's good that we understand this because we are all in the system and it's affecting us. We need to know how we have come so far and what we can still do. Now, countries do not keep changing programs and rolling things up and down because they are definite what they want and they are ready to implement it in a neat and clean environment. Here, the story is different. Now, the rolling plans, 1985 to 1994, was remarkable in Nigeria's healthcare delivery efforts. Look at what happened in this period. Development of a health policy. That's the first time Nigeria developed a health policy based on primary healthcare. It is based on primary healthcare because the whole world, the global community decided that people, no matter where they are, should have access to a level of health that will enable them to live economically healthy life. This is what primary healthcare is supposed to achieve. Primary healthcare is not primary care. Primary care is the first contact. Can be the chemist, can be native doctor, it can be anybody. That's the first contact is primary care. But primary healthcare is a movement. Primary healthcare, some of you know the definition. Essential health based on certain things and has some features. Essential health because it targets the basic health needs of the people. Basic health needs of. You use local technology that people can understand. It's acceptable to them. And it commands their full participation. And the country can maintain it at each level of cost that they can maintain. This is primary health care. Primary health care is not primary care. Primary care is different. So this is the first time Nigeria develops a health policy that is based on primary health care. It was adopted in 1987, and that policy was launched officially in 1988. It was revised in 1997, 2004, and 2016. This policy became the formal framework to manage the country's health system. Please go on. Now, we continue. The second goal of the national health policy is a level of health that will enable all Nigerians to achieve socially and economically productive. I've already said it. The third one was, its objective is to provide access to primary, secondary, and tertiary health care through a functional referral system. If I ask any of you, what do you know about the two-way referral system? We possibly don't know. Some people know. There should be an effective reference system because naturally, as in other countries, the first entrance, the entry point to the national health system is the primary health care. In any primary health center you go, from there they will refer you to the secondary if they cannot cope. And it's a two-way reference system. The secondary will return. If they finish with you, you are supposed to come back with the referral letter from this secondary to report to the primary health what they have done. If you proceeded to the tertiary, they will also give you a referral that when you finish from the tertiary will return you back to the secondary. The secondary will do their own and return you back to the primary so that there's continuity of care. And it therefore means, as is in other countries, you don't walk into teaching hospital like this. You say, I want to see the gynecologist, I want to see the cardiologist, I want to see the this and that. No, there's a primary point where you enter first, and the system continues. So the system is organized, and you just enter like that, and to any level, depending on what your needs are. Now, the policy implied emphasis on promotive, preventive measures integrated with treatment and rehabilitation in a multidisciplinary and multi-sectorial approach. They used to tell us something here. Now, there is integrated. First of all, we want to emphasize promotive. We have to promote people to live healthy. You have to prevent disease. But in case the promotion and prevention fails, you have an integrated system that provides you treatment. And if the ill health has produced some disabilities or so on, then you have a rehabilitation also. So it's a multidisciplinary, multi-sectoral approach. They used to call it multidisciplinary approach with intersectorial collaboration, everybody playing his role. Everybody, doctors, we should accommodate other disciplines. Everybody is important in this work. We can't do it alone. Okay, go on, sir. Now, the fifth point is that it also implies equity in the distribution of health and health resources. If you want to, this policy we are talking about implies that equity is not equality. Equity means that what is due to you is given you. And so this is applied in the distribution of health and health resources. And some of us that if they ask us to go to the community to do work, we are not likely to go. They ask us to go to certain places. We are very selective where we can go. If we do this, there cannot be equitable distribution of health resources. Some people are supposed to be in the rural areas like some of us, and some people don't want to go there. They live in the area I can sell, and they go and close. When they close, the health center is closed by 2 or something. It also provides for all citizens to have right and duty to participate individually and collectively in planning implementation of health services. You see where issues like the ward development committees, the village development committees, the boards, they come in because the people themselves to be part of the planning, where a man's resources is, a man's treasures is, his heart will also be there, and he will make sure it works. The seventh program is that the role of the 3 tiers of government also well defined in the policy. The 1997 revision introduced auxiliary policies of the main health program. Have the main health policy, but auxiliary program like HIV/AIDS came in the 1997 revision. You see HIV/AIDS coming. Then health management information system. That was the time that policy also came in. Please go on. Go on. Now, our country is a country of multiplicity of documents, whether they are implemented or not. Look at this National Strategic Health Development Plan. We have left what we were talking about, national, the other plans we mentioned earlier. But now is national, this one is particularly health. It's not National Development Plan or national, this one is Strategic Health Development. Plan 1, National Strategic Health Development, NSHDP1, 2010 to 2016. It has the following 8 strategic priority areas. Leadership and governance for health emphasizes the need for effective leadership and governance for health. Emphasizes the second point, health service delivery, health services delivery. Emphasizes human resources for health. Emphasizes financing for health, national health management information system, partnership for health, community participation and ownership, and research for health. Now, go to, yes, after they reviewed National Strategic Health Development Plan 1, ETE means end-term evaluation. End-term evaluation of National Strategic Health Development Plan 1, which we just talked about, what it emphasized. Now, after reviewing it, now, the recommendations after the review National Strategic Health Development Plan 1, they say that there's a greater focus on service delivery through the essential package of health services. They now say there's a need to a package, what they call essential package of health services, what every Nigerian is entitled to. Number 2, that we need to define norms and standards of care at various levels of healthcare system. I'm happy that the CMDA is talking about this, because we need to know what the system and what our role is supposed to be as the light of the nation. What are the norms and standards of care at various levels of healthcare? If I ask anybody, nobody will tell me. Maybe a few people will know whether there are standards of care that is established, because unfortunately, the patients see us and we look at the patients as, how do I call them? Captive audience. Captive audience. They have no authority. They have no power to suggest or know anything. But we just do our own. I want to say, for those of you that use the knife to cut or do some other things, you just bring a paper and tell the player, please sign here, sign here. The patient is signing informed consent, and the patient is not informed about the consent. Just bring it, rush out. One person just bring a rush out, you sign. There should be norms and standards of care at various levels and accelerate actions towards primary universal health coverage by strengthening primary health care, by consolidation of world healthcare system and strengthening referrals and emergency medical services. Remember, before the world, the political world was different from the health world. But by the World Health Organization initiative about the year 2000, they say, let the political world and the health world be the same, so that they have a council representing them who will be the community representative, be the mouthpiece of the community in things. So if that person is part of the world health system, then you are increasing, you are strengthening the world health system by making the counselor a relevant person in the management of healthcare. It should be part of the World Development Committee, the people that run the primary healthcare. Okay, go on. Good. The recommendations after the review of, after the end-time review of the National Strategic Health Plan of 1, you have to strengthen the supply chain management system to ensure sustainable supply of drugs, vaccines, and commodities, especially life-saving commodities. You discover that many times shortage of drugs, essential materials up to today is a very big hindrance in our effort to render quality care to the people. The other one is to review and strengthen community-based healthcare services provision through harmonization of community-based healthcare providers and promotion of community participation back to improving community participation, harmonizing the services of all the people that are involved in community services. The other one is to set up actions to expand coverage and reduce financial barriers through social health insurance and improving government funding to the health sector. We are going to see the result of these recommendations, the last set of recommendations after the review of the end-term review of the National Strategic Development Plan 1. You see, improve the performance of health management information system, HMIS, generation and use of health data and evidence for decision-making, and institute a system for continuous improvement of quality of healthcare. You remember that if you don't have data, you will not analyze it to make an informed decision. So improving the performance of health management information system was important because of those of you who do studies. You know what this thing means in the hospital when you have a good health data. Strengthen coordination of the health sector investments and response. Okay, go on. Good. Those were the recommendations of National Strategic Development Plan 1. Now, this is National Strategic Development 2. It's organized into the following 5 strategic pillars. If you look at the recommendations and then review of the National Strategic Development Plan 1, you can understand why these were the emphasis. Number 1, it's organized into the following 5 strategic pillars. This one was organized into 5 pillars. Enabled environment for attainment of sector, enabling environment actually for attainment of sector outcomes, which focuses on leadership and governance, community participation, and partnership for health. You can see where the emphasis is still coming. Sector outcomes. We want to environment that for attainment of sector outcomes, the outcomes of interest, and the focuses on leadership and governance. You know, among the factors of production, no matter where you are talking about, is governance, leadership, management, human resource, and we needed to have community participation and partnership for health. Now, there is increased utilization of essential package of healthcare services, which covers, now they introduce essential package of healthcare services for the people. It includes reproductive, maternal, newborn, child, adolescent health, and nutrition, communicable and non-communicable disease control, mental health, care for the elderly, and neglected tropical diseases, NTDs, neglected tropical diseases. Strengthen health, which focuses on human resources, health information system, medicines, vaccines, and other technologies, and then research. Protection from health emergencies and risks, and increased sustainable, predictable financing and risk protection. Go on, we'll see where this one led us to. Now, we go to another program called the Basic Healthcare Provision Fund Strategy and Universal Health Coverage. I've been talking of universal health coverage, community participation, strengthening management, and all kinds of things. Now, the program on ground to help us achieve financial risk protection. Well, first of all, access, coverage and access. One component, one thing developed was this Basic Health Provision Fund. Now, let's look at it. The National Health Act of 2014 provides for increased access to primary health care and financial risk protection, which are the two strategies for enhanced or achieving universal health coverage. We're saying that cannot be spent out of pocket. Increase access to primary health care. It means that the services are available. The second is financial risk protection. You have to protect the people from financial catastrophes, spending out of pocket. This is what basic care prevention fund tend to achieve. This brings us to some of the critical issues relating to health policy and the 2014 National Health Act, which is number one, National Health Insurance Authority Act, Basic Care Prevention Fund, and care provider responsibility. Remember, we have said earlier, for the first time, they introduced the care for the elderly people. Now, this basic health care provision fund, the basic health care provision fund, or the fund, established under Section 11, Section 11 of the National Health Act, as the principal funding vehicle for basic care provision fund. We're talking of protecting people from financial risks and financial catastrophe. So this was one step. This basic care provision fund was supposed to provide and protect people from catastrophic spending out of pocket. Attendant upscale arising from applications of this funding would assist Nigeria achieve universal health coverage. Yes, it will help us to achieve universal health coverage, UHC, if we have this fund operational. Funding of the basic healthcare provision fund would be derived as stipulated in the Act from contributions, including number one, an annual grant of not less than 1% of the consolidated revenue of the federal government. Number B, grants by international donor partners and funds from any other sources. Please go on. The National Health Act sets out 3 gateways to disburse the basic healthcare provision fund. You know, 1% of consolidated revenue of the federal government is big money. It's big money. How did they want it to be distributed? They called it payment gateways. And there are 3-fold. 50% of that money to be distributed through the National Health Insurance System, which is National Health Insurance Authority now, and deployed towards the provision of the basic minimum package of health services. You know, they organize some basic minimum package of health service, about 6 of them that will be used, will be taken care of by this basic healthcare provision fund. Those 6 basic minimum package of health services, there are 6 elements in eligible PHCs and secondary healthcare facilities. This will be operational in eligible PHCs. You can see the funny thing here now. How will primary healthcare be eligible? Who is supposed to, first of all, strengthen the primary healthcare in terms of facilities, manpower, and everything to make it qualified? Then B, 45%, 50% go through the National Health Insurance Authority. Then 45% go through the National Primary Healthcare Agency. Is supposed to enable the primary healthcare facilities, supply essential drug, vaccines, consumables, provision of and maintenance of facilities, equipment and transportation, development of human resources. And the remaining 5% of the fund shall be disbursed through a committee appointed by the National Council on Health and deployed towards emergency medical treatment. Please go on. This NHIA, I've talked of Basic Care Provision Fund as part of the National Health Act of 2014. A result of that, another result of that act is the National Health Insurance Authority Act. The National Health Insurance Authority, the act in 2022, it was passed. Some aspects of the act, apart from insurance cover for all Nigerians, I want us to understand, this is insurance cover for every Nigerian. There is established the Vulnerable Group Fund. The Vulnerable Group Fund is funded from the Basic Healthcare Provision Fund. We have talked about the Basic Health Provision Fund. Now, this Vulnerable Group Fund, including the disabled and the old people, is derived from Basic Health Provision Fund, B, Health Insurance Levy, C, Special Intervention Fund allocated by the government and appropriated to the Vulnerable Group Fund, money that accrues to the Vulnerable Group Fund from investments made by the council and grants, donors, gifts, and any other voluntary contribution made to the Vulnerable Group Fund. Go on. Go ahead. No. Why were you rushing? Oh, sorry. Well, please go back. Let me make sure that I don't miss anything because they are connected. Go back. Okay. Continue. Go front. Good. These are top. I'm giving a summaries of what we need to know as doctors practicing in Nigeria and as Christian doctors. The top health policies announced by the federal government in 2023. iHealth takes center stage with 3 policies. There were 3 policies on ICE. That's number 2, national task sharing. National task shifting and task sharing policy to combat non-communicable disease. I want to explain this one. Some of you may have not heard. Task shifting and task sharing means that even people that are not, because many of you, even those listening to me, there are places they will send you to, you not go to practice, you refuse to go, you say you don't want to go there, you want to go to Gariki, you want to be my Tama, you want to go to certain places. But every Nigerian, whatever they are, including our to rich areas, are entitled to a level of health that will enable them to live economically productive life all the days of their life. Now, task shifting means training people who are not necessarily certificated, but training them to do some minimum regulated job. You can, like cardiovascular, hypertension people and endocrinology people, they are training ordinary people, or even retired healthcare workers and so on, how to measure blood pressure and to help patients to take their medicine, even if they stay in hard-to-reach areas that you, doctor, cannot go. That's task shifting and task sharing. Making sure that people can handle what ordinarily they will not be able to handle because there is no doctor, in quote. Limited. You see the problem the medical, the nursing and so on, they had with the traditional birth attendants. The traditional birth attendant, an important part of the healthcare delivery system. The people believe in them, whether you like or not, they will go to them. The best thing is to bring them inside and train them on basic. Those of you in the Ops and Ghana, you train them on the basic way to help antenatal women and to make them recognize danger signs so that those people will refer them to the nearest primary health center to become a collection point, people that will help you direct people from their villages to the health facilities. Now, combating cancer with strategic pillar policies. And there were 3 policies here. National workplace policy on HIV/AIDS for Nigerian workplaces. Then policies to reduce suicide and address mental conditions. Remember this as Christian doctors. I purposely brought it here. Policies to reduce suicide and address mental conditions. We'll address some issues about it later. Please go on. Now, another program the government brought was sector-wide approach for health sector, introduced by Prof. Pate, the Honorable Minister of Health now. On December 12, 2023, key health sector stakeholders gathered at the presidential villa to commemorate universal health coverage. This culminated in a historic event, the signing of a new health sector renewal compact by all relevant stakeholders, including the federal and state governments, donors, development partners, and so on. That is part of what gave rise to what sector-wide approach. Please go on. Now, this is a shift that highlight the need for general health initiatives to align with one national plan in the countries in which they operate. Global health initiatives, they operate in many countries. So it is to invest in resilient health systems and align with the goal of programmatic and financial sustainability by supporting increased domestic spending on health. Increased domestic spending on health. Now, some of you remember that Abuja 2020 declaration said that at least minimum of 15% of the national budget should go to health. Every year, Nigeria gives 4 point something of the national health or national budget. This year, I think it's 5 point something. It is quite dismal, abysmal. That is why you can see that the health sector is not funded and it's difficult to operate. Now, global health initiatives, they say this essentially is what the new Nigerian health sector-wide approach is looking to achieve, to align resources toward building a more effectively coordinated, resilient public health sector. Go on. Now, the Federal Ministry of Health has a 4-point agenda. Number one, enhancing health governance and leadership. You know what that means. You know, just trying to create a good governance system to improve the operations of the health sector. This emphasizes the need for enhanced quality of governance and leadership in hospitals. All of us are in hospitals, and many of us do not know we should try to enter into management positions, administrative positions. Many people go into management, they don't understand what it is. It's just that it is my turn, or I am qualified, this to be that. There should be emphasis on the need to enhance quality of governance and leadership in hospitals, including tertiary and teaching hospitals. Regulatory institutions like NAFDAC will be strengthened also. Please go on. That's the first point. The second point is improving population health outcomes. When we say improving population health outcomes, you understand that if the inputs in health are properly and adequately and appropriately utilized, health outcomes will improve. They target improvement in population health outcome, specific health issues such as diphtheria, measles, vaccine, preventable diseases, maternal health, and child health will be the central focus. And you know that in some places, the attrition rate for vaccination is so high. You have 100 people starting with oral polio and maybe Penta 5-1, Penta 5, the first Penta. By the time they finish, about only 20 people maybe finish. What happens to the other people that didn't started from Penta 1? They didn't complete. What happened? They disappear into the community and life continues. So we want to improve health outcomes. So these things need to be tackled. Minister Pate emphasized that entering the healthcare narrative, altering the healthcare narrative depends on collective efforts involving families, communities, healthcare professionals, me and you, and political leaders, everybody. Now, the next one is promoting medical industrialization. This, trying to industrialize and produce most of the things we did from here. Well, God knows how to help us. Then this agenda seeks to boost Nigeria's pharmaceutical and healthcare manufacturing capabilities, reducing dependency on import and strengthening the domestic healthcare supply chain. Of course, they have to be a conducive environment for this thing so that we can produce what we use here. The fourth part, the 4-point agenda, the fourth point is strengthening health security. The fourth pillar of the agenda focuses on health security. The aim is to ensure that Nigeria is adequately prepared and capable of responding effectively to disease outbreaks, epidemics, and humanitarian crises. You see, you can't avoid epidemics and humanitarian crises. There was flooding in Jos. Not long ago, it was outbreaks some diseases, whether it be Lassa fever, whether it be whatever, whether it be COVID, capacity to respond. The Minister Pata emphasized the importance of investing in public health care capabilities, including surveillance, to respond promptly to outbreaks and safeguard national and regional security. Go on. In addition to these 4 keys, Minister Pate highlighted the significance of social welfare, emphasizing the need for a holistic approach. Look at the word holistic, so they can relate it to our own motto as CMDA people, to healthcare that spans from pre-conception through early childhood, adolescent, and adulthood. And those of us as Christians will now add the total man, caring for the total man. Please go on. The healthcare provider responsibility, we end with this. What is your responsibility? What is my responsibility in the law? And many of us are going away with so many things that the day somebody who has known the law will take somebody to the court, my prayer is that it will not be a CMDA member. It must be other people. Now, the health says that a healthcare provider shall not refuse emergency medical treatment for any reason. You know that many times they say there's no police report. I hope we should take note of this. By law, you cannot refuse any emergency medical treatment for any reason. So let's be warned. The health establishment shall protect the healthcare provider from injuries and infections. Of course, we must work in an environment that will not expose us to injuries. And then hospital-acquired infections must be minimum. We have to have protective equipment, personal protective equipment and gadgets and so on, and take the necessary universal precautions. Except for psychiatric cases, a healthcare provider can refuse treatment if the patient is physically or verbally abusive or sexually harassing. These are the conditions under which you can refuse. Go on. Now, explain to the patient the details of his sickness, the diagnostic procedures, the treatment options, except if the information will harm the patient the more. The only information you withhold is the one that will harm the patient the more. Outside of that, and of course, a doctor should know what is risk management of information like this, how to risk communication, how to do risk communication, how best to do it. But ordinarily, the patient is entitled. Many of us do like soldiers. The patient is, as I said, the patient is treated like a captive audience. Patient is just anything the doctor says. Even the patient is afraid that if they make trouble, you can inject them, they will die. They are afraid. Some patients even believe that if you annoy the doctor or the nurse, they can give you injection to that. You can understand how they look at us. We should come out from the mask and relate with the patients as human beings and explain what they need to know. Please, not informed consent. People must understand what they are signing. I thought if it was a physical meeting, we will have discussed it, but we can talk about it in groups. Informed consent means that the person has read, understood, and given you. That's why it's called informed. It's called informed. In other words, the person signing is totally informed about it completely. Then they need to make a difference in our calling as CMDA members. Everything we have been talking. It talks about universal coverage, quality of care, client-centered care. Quality care means meeting and exceeding the needs, meeting the needs of both the provider and the client. Well, as a practitioner, you should meet the needs of the consumer of your services. And if you are not called, you cannot do it. That is why the work of the medical doctor, is actually a calling. We say in the beginning, it's not a career, it's a calling. And so there's a need to make a difference. assumed. Let's take the people as human beings. I have experiences to share in the question and answer session. Please go on. Good. I have tried to run over a very big program. The policies, like so many policies, hypertension, sexual transmission, malaria, all kinds of policies. There are plenty. So I've tried to summarize what we can take here now. And please, it is time to stop. And thank you for your audience. I'll be ready to take your questions. Thank you.
Thank you very much, sir, for an abridged version of an elaborate policy, given the history from where the policies came from. I'm seeing some things for the very first time, and I'm wondering how we landed where we are today, especially the fragments, the ratio of how funds are supposed to be shared, and that there's even an allocation in primary healthcare that there are eligible healthcare and primary healthcare facilities and secondary facilities that are supposed to benefit from it. A question would have come from there. What are the eligibility criteria and whether there are examples of hospitals that have been able to meet it? Because 50% is a big ratio. It's very so big. Huge amount of money. And, so that's where my question would have come from. All right. So, so far, thank you so much. Very good presentation, very lucid, very, very, very enlightening. Thank you so much, sir. We have some questions in the chat box. I will quickly just read the questions so that you can respond from them.
Okay, please.
Has there been a national evaluation of the health management information system? Has there been a national evaluation of the health management information system? How effective is our health data collection systems? Are there any evaluations ongoing? So basically, we're just asking about the same thing, health management information system. I don't know, has there been any evaluation with regards to that, sir?
Let me take it from there. Yes, there are regular evaluations, but I think instead of emphasizing the evaluations, I want to let you know something. When you see patients and they tell you to write age and you write AD, adult, that is a problem already because there's nothing called adult. There is, when you, in statistics, you arrange age, maybe 0 to 5, 1 to 5, 6 to 10, 11 to 15, 16 to 20. So when you write age, adult, where will it fit into? In pediatrics, some of you write a child. Let's start from there. If the health management information system is so critical that I'm happy you're asking this question because the correction will come from you and me. How do we collect data from the hospital? How do we fill forms, lab forms? You must fill it in details. Thank God for electronic medical recording now. Details must be given. Details. See, our health system is not performing. One of the reasons is that the poor data collection. You can't even assess anything. You can't determine anything because data is rare. So there's evaluation. They used to do evaluation, but I don't think it's a national thing. Maybe they can evaluate. I think there was a time they do some evaluation, but it is done by Health Management Information System Group. I don't know the last time they did it, but I think what we should be concerned as doctors, because it is we that generate the data, and we generate the wrong things. Age, you cannot say exactly where the patient is from. You cannot write so many things. So let us go back. What I will only say, I'm happy you ask this one, is that we should go back and fill correctly any data paper as doctors. You are supposed to, those of you that do research, when you go to secondary data collection, you go to the folders. Those days, you see that you have nothing, you cannot get any data because the information is collected in such a way that the things you need will not be there. But they do evaluation. I know they do, public care does it, but I don't know the time they did the last one.
All right, thank you, sir. I think a strong take home from there is to make sure that we make our data complete.
Yes.
All right, so the next question, will public-private partnerships solve the government's poor health funding problems?
I think that it will help. But remember, the head needs to be sane for the body to be sane. If you do public partnership, it will be very good. But with the current state of human beings and organizational structure and management capacities we have, they say, comma, it is difficult. Private partnership, public-private partnership will help. And it's helping in some places where people have taken it up. But it is, the conditions are also very difficult. And you have to have a big muscle to do that public-private partnership with government, for instance. It's not easy. And the bureaucracies, the issues involved may make it very cumbersome and very difficult. But we are praying. I'm emphasizing this because we need to take interest in governance and leadership positions. Please, we need to take interest in governance and leadership positions as Christians. It can change things. The idea of leaving it for them and going to pray is wrong approach. Don't go to pray alone. Get involved and pray. Don't leave it for them. I'm interested here because I needed to emphasize that we should get involved in management activities in organizations. We should want to be CMD, CMAC, want to be head of this, and we want to get interested in what is happening in the hospital. Let's know what is happening in the health information management department in our hospitals. Let's know how data is collected. Let's know what is happening. Even if you are not doing research, just try, because if the things are collected well, thank God for the hospitals that are doing electronic medical recording. I hope that the data is being complete.
All right, thank you, sir. Next comment, thank you so much, sir. Now we have another comment. Many thanks for the lucid presentation, sir. Very enlightening. The next comment, patient-centered care is the minimum standard, and
Yes.
only one equipped to care for the whole man can do this properly. Jesus asked Bartimaeus, what do you want? Jesus didn't assume his need. He wanted to hear him out and tailor interventions to his needs. Thank you for that. The last one too is also a comment and not a question. The issue of evaluation of national policies and strategic plans at national level was raised and briefly discussed at the 64th National Council on Health meeting held in Ado Ekiti in 2023. It's very important to determine the relevance, progress, and impact of our policies and plans. Thank you so much for that.
Thank you.
All right, in the absence of any question or comment in the chat box, I want to thank you so much, sir, for your time, and thank you so much for this Herculean task of summarizing many documents and the policies of over the years. For me, they are very vital take-home points, especially in the era of many issues coming up. The issue of violence against doctors, that happened so much around last year, and now I'm seeing a policy that first mandates the establishment to protect its own health workers against all of those abuses and both verbally and even hospital-acquired infection. Now I'm seeing that it's the job of the hospital to protect, and also I'm seeing that the provision that the healthcare professional can refer care to another physician if the patient is being verbally, physically and even sexually abused. Yes, sir. So thank you so much for that. Okay, I still have one more question. Two people are thanking for the presentation. One question. Why is our insurance coverage still low despite the basic health care fund? As I said, I wanted to, the sharing formula of that money. So despite all of that money, why is our insurance coverage still low? Is there something we don't know, or are there people who are not asking the right questions to? Maybe that will be the last question before we go for the day, sir.
Yes, thank you. I'm so happy for these questions too. I share an experience, but keep it with us. I helped to revitalize a world development WDC, World Development Committee of a primary health center where I had interest. They were not working. I caused one of my students who was an MPA student who works in that area council. I held his trachea, say he must give me the list of the members of the WDC since I don't have capacity. Only the National Primary Care Development Agency can do it. So give me the list. I reconvened them and trained them on how to operate. We were doing very well. Suddenly, I was ejected from I was no longer informed for meetings. They were doing meetings. It was when basic care provision funds started landing. I was removed from the list. I didn't know when they're having a meeting. Now, they ate the money by the people who operate. That fund is supposed to be, if the head of the health or the health committee, they have a need, they will meet and present the need to the World Development Committee. If the World Development Committee approves it, then they go to the bank and withdraw the money, and it will monitor how they do it. By this Kasa Hanu Kawai, they put Hanu and they eat the money. They wanted to close that facility, but it came back. I'm just telling you why things don't work in Nigeria. This is, and in the first place, again, how you are talking of eligibility, it is the Nigerian health system that should make the primary health care eligible. What are the indicators? What are the parameters? Health, human resources, facilities, and all the things that are available. Who is supposed to provide it? The same government. The government will say that these people don't have this, don't, so they are not eligible. You keep them out. But those that are eligible, the human beings there want to work for their pocket. It's a complex thing, very complex. That money is there. You can imagine what 1% of national consolidated revenue. Then you ask the National Primary Care Development Agency, what are they doing with the 45%? How far are they going? Then the National Health Insurance Authority, 50%. Then 5%, the National Council on Health to determine the emergencies and so on. My bros, let us as Christians enter inside to know what is happening. Let's fight the war from inside. Thank you.
All right, thank you very much, sir. Thank you so much. I'll be handing over the meeting to Dr. Alex Etubi.
Thank you.
Okay, thank you very much, sir. Thank you so much. We call him Igwe. This has been a very enlightening session for everyone. Thank you so much for taking our time to do this. We know it had to do with a lot of researching, reading, and getting your slides ready. And we do not take this for granted at all. So we're really grateful. Thank you so much. We pray that God will bless you. He will renew your strength. Amen. And he will give you more opportunities to continue to be much blessings to us. Thank you so much, sir. I want to thank everyone who has really joined on this the session from everywhere. And very importantly, to let us know that our president is here, even on in this webinar, on this session. And I'll be calling him for his final words and then maybe to close with us in prayer. I also want to thank every governing board member who is here and who joined. Our students who joined too, thank you so much for coming. All of this is very relevant for your practice in the future. And like the presenter mentioned, some of these aspects he touched on, they are not the common things that we clinicians are conversant with. So there's so much to learn. And we'll be sharing the videos after it has been cleaned again, so we can listen over again, and would also share his contact, and we can reach him after now. Thank you so much, Dr. Vongdip, for anchoring the session as well. I want to thank the Gwagwalada chapter chairman, Bro Victor Ame, for coming in at different times. So thank you everyone for coming. Despite the initial technical hitches we had, you will agree with me that it ended well. And that is the summary, that everything went well at the end. Thank you so much. So may I now please call on the CMDA Nigeria President, Dr. Gimba, to give a word and then maybe close in prayer. Thank you, sir. Okay, sorry, just trying to confirm. Am I being heard? Okay.
Can you hear me?
Yes, please. Thank you, sir.
Okay. Sorry, I was trying to unmute, but then it wasn't allowing me. Okay, so thank you very much. And we are very grateful to our speaker for allowing God to use you in this way to enlighten, educate us. And thank you also for all the challenges raised and issues discussed. Our prayer and our desire is that CMDA will go beyond just a body of Christian doctors who would sit down, look at a problem, and then that's just it. But we must go beyond that to even engaging authorities, proffering solutions, and saying this is the better way to do things. And so again, thank you so much, sir, and may God continue to bless and honor and prosper you. And
Amen.
to all those too, thank you for tuning in. Thank you also for all the questions. That means we were following. It wasn't
Yes.
a presentation. We enjoyed it. So God will bless us. We've all been well educated. All right. So did you say I'll pray also?
Yes, please. Thank you.
Okay. Okay. So let's go to God in prayer. Lord, we are grateful people, because thank you so much for even raising from amongst us great and capable people who know the right word for the season. Thank you for our speaker. Thank you for using him mightily. Thank you for all that he has said to challenge us, to educate us, to open our eyes to some of the things we didn't even know. We pray, oh God, that as an association, you will cause us to grow. You will cause us to stand. You will cause us to be solution providers to this myriad of health challenges that we have as a nation. We're grateful, and we ask that you will dismiss all of us with your blessings. You will grant us a great weekend. You will cause that whatever it is that our hands finds to do shall prosper. Thank you so much for hearing us. In Jesus' mighty name we pray.
Amen.